Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep to Go, and I wanted to tell you about our MedPrep to Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com.
Hi, and welcome to the MedPrep to Go USMLE Step 2 podcast. I'm Dr. Raj, and who am I? I'm a quadruple board certified doctor in pulmonary, critical care, sleep medicine, and my favorite, internal medicine. And right now I'm the associate program director for internal medicine residency, and I love teaching. And talking about USMLE stuff is one of my biggest passions. So what is MedPrep to Go? I mean, our mission is to improve medical student wellness and reduce educational debt by providing high quality USMLE question bank that is online and in an audio format, by making medical education material available to study on the go. That means while you're working out, while you're walking, while you're doing the laundry, we strive to give you time back in your day to focus on your health and well-being. And how does this go? I'm going to read 3 USMLE Step 2 questions. Today's is going to be from, oh man, I'm so excited, cardiology. And of course, go to the website to follow along with the questions and to get all our questions, which are free. So let's do our first cardiology question. This is a 55-year-old man presents to the emergency department with severe tearing back pain that abruptly started 2 hours ago. Stop right there. The minute you say tearing back pain, oh boy, what is, and I gave it away, it's cardiology. What is your differential diagnosis? Yeah, someone just yelled it. I can't believe you nailed it. I'm thinking aortic dissection, but that's just me. Let's keep on reading. He describes the pain as maximal at onset and radiating between his scapula. He has chronic hypertension and hyperlipidemia. Stop right there. Are those risk factors for developing or having aortic dissection? Totally. Oh man. And it says that the high blood pressure and high cholesterol are not treated. Can't be good. He smokes 1 pack of cigarettes a day. No bueno. And has 3 bottles of beer daily. Maybe it's non-alcoholic. I don't know. Go figure. His blood pressure is 180 over 100 in the right arm and 155 over 95 in the left arm. Physical exam shows a man who appears uncomfortable. What a surprise. Otherwise, the remainder of the exam is unremarkable. An ECG shows non-specific ST segment and T-wave changes. Chest X-ray reveals, a little cliche. Okay, everyone listening, if I were to shoot a chest X-ray and the person had aortic dissection, what do you think you're going to see on the chest X-ray? Wow, you folks are so on it. Yeah, widening of the mediastinum, and that's what it says right here in the vignette. Which of the following is the most likely underlying cause of this patient's presenting condition? Is it A, alcohol, B, atherosclerotic plaque rupture, C, chronic hypertension, D, nephrolithiasis, or E, tobacco use? And the correct answer is, oh, you nailed it, C, chronic hypertension. So the clinical presentation of this patient strongly suggests acute aortic dissection characterized by the severe abrupt onset of a tearing back pain that radiates to the abdomen and is maximal at onset. While the pain is typically described as an anterior chest pain and located, while the pain is typically described as anterior chest in location in ascending type A dissection, For descending type B dissection, the pain is more often experienced in the back. I think that's important. I think that's really important. The significant variation in blood pressure between the arms with a higher reading in the right arm compared to the left is a classic sign of aortic dissection. Additionally, the chest X-ray reveals mediastinal widening, the ECG showing nonspecific ST segment and T-wave changes further supports this diagnosis. Among the risk factors presented in this vignette, chronic hypertension is the most significant, being present in more than 70% of aortic dissection cases, particularly in older individuals. Chronic hypertension weakens the aortic wall over time, making it more susceptible to dissection. So answer choice A, alcohol is incorrect. No, while alcohol can definitely contribute to high blood pressure, it's not directly linked to the mechanism of aortic dissection. Choice B, atherosclerotic plaque rupture, is incorrect. Don't get me wrong, everyone. Atherosclerosis can be a risk factor for aortic dissection, but it's not as strong as chronic hypertension in this context. Choice D, nephrolithiasis, is incorrect. Nephrolithiasis, which this is not, typically presents with flank plane hematuria, which are not consistent with this patient's severe tearing back pain. And the findings of mediastinal widening make no sense if you had nephrolithiasis. And of course, nephrolithiasis is not a risk factor for aortic dissection. Answer choice E, tobacco use, is incorrect. Smoking is a significant risk factor for atherosclerosis and can also contribute to hypertension, but chronic hypertension, which is the correct answer, is the most important risk factor for aortic dissection. But being a pulmonologist, let me just say, don't smoke. So what is the key learning point here? Chronic hypertension is the most significant risk factor for aortic dissection, causing weakening of the aortic wall and making it more susceptible for dissection. And once again, I loved when I was kind of misreading it a little bit or misspeaking, I don't know which one it is, that talking about the pain with type A dissection, think about it in the chest, radiating to the back, versus when we talk about type B, think of more of the abdomen, going towards the back. You guys want to do another one? All right, cool. Let's do one more. I promised 3, didn't I? So next question is a 65-year-old gentleman presents to the emergency department with severe tearing chest pain radiating to the back that began 90 minutes ago suddenly. Wow. Is there a theme here, everyone? I almost thought I read this question already. It seems like it's going very aortic dissection here. But he has a history of chronic hypertension, but stopped his medications 2 months ago. Bad call. He smokes 10 cigarettes daily. And drinks 8 alcoholic drinks per week. Okay, that's 1 a day. His blood pressure is 190 over 110, and his heart rate is 115, so tacky. Physical exam reveals tachycardia, but is otherwise unremarkable. An ECG shows sinus tach. Evidence of left ventricular hypertrophy is noted on the ECG and T-wave inversions in lead V5 and V6. A CT angiogram of the chest shows an intimal wall flap in the aorta. Which of the following is the most appropriate next step in management of this patient? All right, do you want to do A, captopril sublingual, so a sublingual ACE inhibitor? That just doesn't sound right to begin with, but all right. B, hydralazine intravenous. I know I should read all the questions first or answers, but let me just throw my 2 cents for hydralazine. That will lower the blood pressure, but you definitely get some reflex tachycardia. And the patient's already tachycardic and has aortic dissection. That sounds like not a good choice. C, labetalol intravenous. So labetalol is an alpha beta blocker. So it blocks alpha 1 and, of course, beta 1. Kind of like that one. All right. D, nitroprusside intravenous. Anytime you say nitroprusside, everyone kind of freaks out because they're like, oh my God, I'm going to get cyanide toxicity because the metabolite's thiocyanate. I'm not against lowering the blood pressure with nitroprusside, but once again, you got to do something with the heart rate. So I'm not feeling D. And E, it literally is warfarin orally. Like, I don't know. Why would you want to anticoagulate this patient with possible dissection? That sounds like not the right answer. I'm going to go with C, and the right answer is yes, D. The clinical presentation of this patient strongly suggests aortic dissection, acute, characterized by the sudden onset of severe tearing, chest pain radiating to the back, along with the findings on the CT angiogram. The initial management of acute aortic dissection focuses on reducing aortic wall shear stress and preventing further propagation of the dissection. This is achieved through anti-impulse therapy. Anti-impulse therapy is a medication regimen used to quickly manage blood pressure and heart rate in patients with acute aortic dissection and acute aortic syndromes. The goal is to reduce aortic wall shear stress and change the aortic pressure over time. The main line of therapy is to decrease the resting heart rate to less than 60 beats per minute and maintain systolic blood pressure of less than 120 millimeters of mercury. Anti-impulse therapy is usually achieved with IV vasodilators and beta blockers, ideally in the intensive care unit with an arterial line monitoring, an A-line. Good. The 2022 American Heart Association, American College of Cardiology aortic disease guidelines recommend IV beta blockers therapy as first-line treatment for acute aortic dissection. Beta blockers reduce blood pressure by blocking the effects of epinephrine or adrenaline, which relaxes the heart and slows it down. Intravenous beta blockers like labetalol and esmolol are the preferred therapy as they decrease ventricular contractility, blood pressure, and heart rate, thereby reducing aortic wall shear stress. Labetalol has the added benefit of alpha-1 receptor blockade, causing peripheral vasodilation and further blood pressure reduction. Adequate pain control is crucial as it reduces sympathetic drive, lowering blood pressure, heart rate, and contractility. If beta blockade alone does not achieve a systolic blood pressure of less than 120 millimeters of mercury, intravenous nitroprusside can be added. Choice A, captopril sublingual, is incorrect. Captopril sublingual is an ACE inhibitor that can lower blood pressure, but is not effective as beta blockers in reducing aortic wall shear stress and can cause reflex sympathetic activation. Choice B, hydralazine intravenous, is primarily an arterial vasodilator. Excuse me, everyone, which can increase aortic shear stress and typically avoided in acute aortic dissection. Choice D, nitroprusside, is incorrect. Nitroprusside is useful to lower blood pressure. However, it should only be used after beta blockade is established to prevent reflex sympathetic stimulation. Choice E, oral warfarin, is incorrect. Warfarin is an anticoagulant that is contraindicated in aortic dissection due to the risk of aortic rupture or extension of the dissection into the pericardial space, causing a hemopericardium. So what is the learning point here? Acute aortic dissection, intravenous beta blockers such as labetalol are preferred in the initial management to reduce blood pressure, heart rate, and aortic wall shear stress. All right, we've got two back-to-back aortic dissection questions. I'll let both of them. They're definitely high yield. Let's do one more to make the full three.
Planning a wedding shouldn't feel overwhelming. The Knot brings everything together in one place. Vendors who get your vibe, a custom planning checklist, guest list tools, and a free wedding website that syncs with it all. So instead of juggling a dozen apps and spreadsheets, you can actually enjoy getting married. Get started at theknot.com/audio. The Knot. Let's plan your wedding together.
Score more with the college-branded Venmo debit card and earn up to 5% cash back with Venmo Stash. Got paid back? With the Venmo debit card, you can instantly access your balance and spend on what you want, like game day snacks, gear, tickets, and more. The more you do, the more cash back you can earn. Plus, there's no monthly fee or minimum balance. Sign up now at Venmo.com/collegecard. The Venmo MasterCard is issued by the Bancorp Bank N.A. Select schools available. Venmo Stash terms and exclusions apply at venmo.me/stash terms. Max $100 cash back per month.
We have a 68-year-old woman presents to the emergency department with a sudden onset of severe chest pain radiating to her back. The pain started 1 hour ago and is described as sharp and tearing. She has a history of chronic hypertension, hyperlipidemia, and sick sinus syndrome, resulting in placement of a pacemaker. Her blood pressure is 180/100 in the right arm and 150/90 in the left arm. Her heart rate is 110. On physical exam, she appears anxious, diaphoretic, and is tachycardic. An ECG showed a paced rhythm with nonspecific ST segment and T wave changes. Chest X-ray reveals mediastinal widening. It is unknown if the pacemaker is MRI compatible at this time in the emergency department. Which of the following is the most appropriate next step in this patient's management? So, you know what? We're having the trifecta of aortic dissection. In fact, even though I'm going to title this, USMLE Step 2 questions, this is the aortic dissection trifecta. So, which of the following is the most appropriate step in management next? Is it A, aspirin administration and measure serial troponins? This is not the right answer. I'm not going to give an antiplatelet. There's a possible dissection. Patient's really not doing well, hemodynamically unstable. I'm not going to sit here and wait for troponins to come back. A seems wrong to me. B, coronary angiography. I'm not feeling, an acute coronary syndrome here. I feel I'm really worried about dissection, almost to the point where does this patient need to maybe have surgical evaluation? So I don't think coronary angiography is the right answer. C, MRI angiography of the chest. I love proving what's going on first before doing anything emergency, especially committing someone to surgery. But am I going to put this person in an MRI machine? And what about that pacemaker? We don't even know if it's MRI compatible. That sounds like a bad idea. So it can't be C. D, transesophageal echo. Now, I don't know. TEE sounds like the right answer here. I'm sure many people say try a transthoracic echo first and see if it changes your management. But, the good thing about transesophageal echo, if you're in an institution that has it, people can do it. It can be done at the bedside. And the right operator who's very familiar with doing it, it can give you the answers without moving the patient. So I do like D. And E, a VQ scan. Don't get me wrong, I'm a pulmonologist. Why wouldn't I love imaging the chest and working up PE? But this is not a pulmonary embolism, right, folks? Yeah, this is aortic dissection until proven otherwise. So I'm going to go with D, and that's the right answer. So this patient's presentation of a sudden onset of severe, sharp, carrying chest pain right into the back, significant blood pressure differences between the arms, and the widening mediastinum on chest X-ray, highly suggestive of acute aortic dissection. The immediate goal is to confirm the diagnosis and determine the extent and location of the dissection to guide treatment. Recommendations for cardiovascular imaging are based on consensus guidelines. Multiple imaging modalities can be used to demonstrate the dissection, including a chest MRI, a chest MR angiography, CT angiography, and transesophageal echocardiogram. Each of these has its advantage and disadvantages, and one may be more appropriate for a selected patient population as the initial study. CT is the most common initial choice due to its widespread availability, particularly in the emergency department setting, though it was not an answer choice in this question. For patients with suspected aortic dissection, particularly when they are hemodynamically unstable or in significant pain, transesophageal echocardiogram is often the preferred imaging modality. TEE is highly sensitive and specific for aortic dissection and can be performed rapidly at the bedside or in the operating room, providing real-time images that can help confirm the diagnosis and assessing the need for urgent surgical intervention. Choice A, aspirin administration and measurement of serial troponins, is incorrect. These are the part of the workup for acute coronary syndrome, which would present differently and would not address the workup for aortic dissection. Choice B, coronary angiography, is the wrong answer. Emergent coronary angiography is indicated for acute coronary syndrome, specifically ST elevation MIs, not for aortic dissection. Choice C, MR angiography of the chest, is incorrect. MR angiography, although is an imaging modality that can be used to diagnose aortic dissection, it's more time-consuming, less practical for hemodynamically unstable patients, particularly this patient has a pacemaker and it's unclear if it's MRI compatible from the information provided in the above vignette. Choice E, VQ scan. VQ scan is used to diagnose pulmonary embolism, which this patient does not have based on the history, physical, pretest probability. So it's the learning point here. In suspected acute aortic dissection, characterized by sudden onset of severe chest pain radiating to the back and significant blood pressure differences between the arms. Transesophageal echocardiogram is the preferred diagnostic test for hemodynamically unstable patients due to its high sensitivity, specificity, and rapid bedside application. And with that being said, those are our 3 questions today. Hey, to get more info, look at more questions, go to the MedPrep2Go website. That's medprep2go.com to learn more about me, Dr. Raj. Check me out on social media. Check out my book series from Elsevier. It's called Beyond the Pearls. And I will see you next time on the next podcast.
Hi everyone, Chris here from MedPrep2Go, and our friends at Panacea Financial have a scholarship opportunity for $1,000 for underrepresented residents and fellows. Applications are only open until March 20th, so submit yours today. Apply and learn more at panaceafinancial.com. Hey everyone, Chris here from MedPrep2Go, and I'm asking for your help. We are currently running a survey to better understand you, our audience. We're looking for feedback on the podcast, our Qbank, and to see what kind of content you would be interested in so we know how to best direct our efforts. The survey will be open until March 31st. We recognize that your time is valuable, so as a token of our appreciation, we're giving away 2 annual subscriptions to the podcast of your choice for winning participants. Just enter your email at the end of the form, and winners will be contacted in early April. Please take a few moments to help us out and complete the survey at medprep2go.com/survey. Thank you in advance.